So welcome everyone to our program today. I'm very excited to see some old friends and some new friends with us joining. I think there'll probably be a few more come into the room as we go along. And we are very pleased today to have a guest professor, Dr. Zhongxin Yu. She is a professor of pathology at the University of Oklahoma Health Sciences Center, and particularly expert and interested in pediatric pathology, where she has been doing a tremendous amount of work in holding together our pediatric pathology service for over 10 years. And we are grateful to have her share some cases with us at this point. So I'm going to stop the share on my screen, and Zhongxin, you can share your screen and begin to discuss the cases. As we go along, if you have questions, please type them into the chat, and I will try to moderate those and pull those things into the discussion as we go along.
Thank you very much, Dr. Hassel, for your introduction. Hello, everyone. I'm so glad to see you over the over the internet. It's a long time. Can everyone see my screen? It's PowerPoint right now.
Yes, I think it's very clear.
Okay, so so today I'm going to present you some pediatric common tumors in the liver. So all the cases are going to be in the liver. I hope everyone had a chance to look at the digital slides, but I will show you digital slide. Here are some PowerPoint. I use the time sign out the case for our tumor board. So I saved all of them. So give some clinical information a little bit. So first case we are going to show is a 7-year-old boy with abdominal mass. Actually, it's a liver mass. Get the incisional biopsy. At the time of biopsy, the AFP, serum AFP is very high. You can see have to dilute the specimen. Normal range is 1.3 to 2.7. Here's very high, sky high. With this information, let's go to our digital slide. First one, we call the D1. So anytime we look at tissue, we start with look at some normal, where this tumor come from. If there's any normal tissue can indicate us. For today's case, because everything is from liver, so we do not need to spend this kind of effort, but still try your effort to find any normal tissue to compare to normal. I look at this slide, I didn't find much normal residual liver tissue. Here, select low power, you can see that this is like a capsule. I think this is a liver capsule. Close look, I didn't see much tumors. This tumor, you can see it's kind of like a solid tumor, sheath-like, and the low power, you can see some dark area and light area. Dark area and the light area. Same thing here, dark area and the light area, kind of alternating. So let's look at close what those each component looks like. So this is the light area, still dark area. Let's look at dark area first. Close. So what you can see here, kind of a cord-like epithelial cells. The cells are kind of very uniform and with pink cytoplasma, granular cytoplasma. This is the highest power I can go from my these slides. So there's arranged the pink cells, epithelial cells arranged in cord, and kind of mimicking like liver cells. And the cell kind of well differentiated, mimic normal fetal hepatocytes. And look at this whole area, then you go to light area. Same thing, still is like epithelial cells have a clear cytoplasma border and arranged in cord and pseudoacinar kind of change. And in the background, you can see some like extramedullary hematopoiesis. This everything looks like a fetal liver cell, normal tissue, but we do not see normal like a portal tract. So architecture-wise, this is not normal liver. So because very differentiated liver cells, and this is called the hepatoblastoma with this kind of morphology, with this kind of history, high AFP, big liver tumor, and this is called the hepatoblastoma. So usually have this dark area, light area. The light area usually have glycogen. It depends on glycogen content, could be darker and lighter, and with extramedullary hematopoiesis. So this case is, whenever you talk about hepatoblastoma, there are different types. There are fetal type, there are embryonal type, there's small cell and different small cell type. This one, for this specific case, D1 is our fetal type. And when you decide it's a fetal type, you want to decide how much mitosis. If more than 2 mitosis per 10 high power field, that's called the mitotic active type. If less than 2 mitosis per 10 high power field, we call mitotic inactive, we call the well differentiated. The well differentiated type is usually with a very good prognosis. So that's the tumor looks like. Dark area, light area, and with extramedullary hematopoiesis. And this one, we have some mitosis, more than 2. Probably from this screen, I cannot show you, but I can briefly look at this, the time for tumor board PowerPoint, if you can see my PowerPoint. So same features just capture, we just see dark area, light area. This light area even have some like a biopigment. This is like a dark area. Mitosis, we can see here, mitosis more than 2. Mitosis more than 2 per 10 high power field. And you also have the extramedullary hematopoiesis. And the morphology cells are very uniform and no dysmorphic features. And tumor no necrosis. You can do some immunostains. Those hepatoblastoma often have those beta-catenin nuclear staining pattern, and often have a glypan 3. Depending on tumor type, the staining pattern is different. Pure fetal type, mitotic inactive, usually have like canalicular staining. For those mitotic active and embryonal one, you can have this cytoplasma coarse granular staining pattern. So that's this. And anytime we diagnose hepatoblastoma, we want to do INI-1 immunostat, just in case there's like a rhabdoid tumor, and because that have a worse prognosis. Retain RNI-1 is good, rule out that. So this is like a nuclear staining. So how did I send out this case? We call the liver mass, right lobe incisional biopsy, called hepatoblastoma, epithelial type, fetal pattern, mitotic active. So just a quick, review with you the classification for hepatoblastoma, because everyone sees those pediatric tumor often. So this is the consensus classification by COG, Children's Oncology of COG, Children Oncology Group, COG, and also adapted by CAP tumor checklist. Basically, hepatoblastoma have two types, epithelial type and mixed epithelial and mesenchymal component, this mixed. In the epithelial type, you have pure fetal with low mitotic activity. That's the one less than 2 mitosis per 10 high power field. And there's a fetal type with mitotically active, like the case we just see. Pleomorphic, poorly differentiated, that usually have a very prominent nucleoli, more pleomorphic and more malignant looking. That's a pleomorphic one, usually very focal. Embryonal usually cells like more immature compared to fetal type. The cell usually larger, high NC ratio a little higher, and mitotic is more like active. And another one called small cell undifferentiated type. Small cell undifferentiated type have, in general, IN1 should be negative. IN1 positive, usually considered to be rhabdoid tumor. If focal, we have not seen small cell with focal one have a positive, usually negative. If diffuse, and we consider this rhabdoid tumor. Anytime you have small cell undifferentiated type, you want to do IN1. And then epithelial mix, you can have all kind of fetal, can have pleomorphic, can have embryonal, can have small cell or component. If you have epithelial mixed, you better, if this is resection, we usually give the how many % of each component. And there sometimes have cholangioblastic appearance with like a bile duct differentiation. And there's another one called epithelial macrotrabecular pattern. I will show you a case. So all those patterns, I think this like a small cell undifferentiated and epithelial macrotrabecular pattern usually have worse prognosis compared to others. Otherwise, the prognosis is like similar. For the mixed epithelial and mesenchymal component, the mesenchymal component most time is osteoid or bone differentiation. And with this, you also can have a territory feature and no territory feature or with territory feature. So that's just summary about hepatoblastoma. With this information, we can look at our next case. D2, D3, D4 slides come from same patient. It's a young patient, 19 months old, have liver mass. And at time of diagnosis, in serum AFP marker is very high. Again, it's like we have to by dilution get this number very high. This patient had upfront resection. This resection growth of cut surface. This is a little bit residual normal liver. This is a large tumor, very nodular, lobulated. I have some myxoid area, have some like pigment here. It's not a necrosis, it's not hemorrhage. This is a pigment, lots of pigment. And this area probably the osteoproduction. With this information, let's look at slides 2. How is can you see clearly so far, right? Okay.
Yeah, the slides are coming through very clear.
Okay, it's great. So that's the D2 slide from the second patient. This and the low power, you can see there's very, just like we see on grossly, there's some cellular area. There's less cellular myxoid area. There are pink area, those are osteoproduction. And actually, this is like a bone formation, and there is a pigment. And look at those cell closely in this area. Again, you can see just like we saw on the first case, you have some granular, some epithelial cells with granular pink cytoplasm, just like a fetal liver cells. So this area is hepatoblastoma fetal type. This area still is fetal type, but have increased mitosis. So make you variable going to be like embryonal type. But we have a better area with embryonal type. Go here. This area I would consider like embryonal type, have mitosis, cells more blue, insulin higher. This is probably like embryonal type. So there's a mix. This area is like epithelial type with fetal and embryonal morphology pattern. This area is like that melanin pigment. They are more those kind of melanin pigment. And probably it's like there's a, we call the territorial feature, which is like a retinal kind of melanin pigment. So that's that area. And you look at, I will come back to this area. Then you go to this paler area. There's still some hepatocytes, like a fetal type, clear cell. Then you have some fibrous tissue. You have some fat. This is like a mesenchymal component. And there's osteoid and kind of, this is like a more immature bone. And this almost is bone, there's a bone. So far it's epithelial and mesenchymal component. And then look at this area. I said I'm come back later, this area. Oh, this is osteoid and the bone. Like look at this area. There are some small blue cells, but their background have some neural peel, kind of neurish. It's not our typical and different type because there's neural tissue. It's differentiated, this neural tissue. With neural tissue, we call the territoid feature. So this is neural tissue, this neural tissue, like a brain, neural tissue. And it's better when you go this area. Actually, you have neural tube here, immature neural tube, lined by those epithelium, looks like a ciliate. And this on those like a immature neuroblast. So with this feature, we call the territoid feature. So now with this case, we have a fetal type, some area we have embryonal type, and you have mesenchymal, then you have for this, that's for D2. D3, the same patient. Similar, you have like a dark area, light area. I want to show you this. This is more like a fetal type. Here's more like a embryonal type, more blue. And there's a little bit cholangioblastic differentiation. You can see the tumor cells arranged like a form, those like a glandular appearance. This is a cholangioblastic differentiation. And also background to cell very blue, those are embryonal type. Most important, I want to show you this slide, you see, and the low power here, you can see some tumor foci, and in between the tumor, and there's a paler area. You want to look at what the paler areas, what the morphology looks like. And those cells basically is undifferentiated, like small round blue cells. The small round blue cells. Those cells we call the small cell undifferentiated type. This usually, if small focus usually have no, the significance unknown, but it's a large amount, especially more than 75% of the tumor, and usually have worse prognosis. And for those kind of undifferent small cell, we want to do INI1 to rule out the possibility of rhabdoid for this kind. So that's a fetal type. That's a little bit glandular, cholangioplastic, and this area we're considering this is embryonal type. So that's D3. Let's call D4. Same patient. This one I'm going to try to show you is this arrangement. You can see in the low power almost like you can trabeculate arrangement. This kind of type we call the macrotrabecular pattern. Macrotrabecular pattern defines this arranged trabecular. Each trabecular cells more than 5 cells thick, more than 5 cells in the trabeculae. Initial defines 20 cells. That is very difficult to reach, that 20 cells thick. But now the definition more than 5 is called the macrotrabecular pattern. Macrotrabecular pattern, the cells can be embryonal, can be fetal. In this specific case, it looks like more like embryonal type cells. So cells are large, high NC ratio, some nucleoli, and mitosis very prominent. But you can see the big wide trabeculae. That's macrotrabecular pattern. So just quick go, these are tumor board type. The same case, you have fetal like a dark cell, like light cell, and there's extramedullary hematopoiesis. This is like a more embryonal, cells are large, high NC ratio, more prominent mitosis. And this osteal differentiation, pink osteal production, and this like epithelial cells. And this is the neural area with pigment. That's neural tube formation territory feature. And there's a kind of squamous foci with the melanin pigment. This also considering territory feature. This is small cell undifferentiated type. There's no differentiation, and the cells, small round blue cells. Just show you some immuno feature for small cell undifferentiated. And because they are undifferentiated, so hyper 1 usually negative compared to neighboring like embryonal or small cell type, they are usually positive. Small cell component usually negative. And also pancytokeratin, very minimum staining compared to neighboring tumor cells. Beta catenin usually strongly positive, nuclear staining, diffuse strongly. So there's no RNI1 loss, nuclear staining present. For this specific case, somehow the expression is a little bit low. I'm not sure why. And some others experiences said that small cell undifferentiated component RNI1 usually more stronger staining compared to neighboring cells. My experience sometimes low, sometimes equal, but should no loss. Loss is no good. Of course, for resection specimen, we want to look at the margin, positive and negative. For this one is a positive, and looking for intravascular invasion. So how did I send out that case? I call liver mass, right lobe, lobectomy, hepatoblastoma, mixed epithelial, and mesenchymal type with territory feature. And there's a focal small cell and different pattern. You give the amount. So usually less than 10 and less than 5 or less than 10, more than 75% we usually said more like a kind of worse prognosis. And focal macrotrabecular pattern also we give how many. The margin, of course, give COG stage, and there's intravascular invasion for this case. So that's about basically about hepatoblastoma. Next one, probably you have slide D5. It's similar like a fetal type hepatoblastoma, maybe I just show you this to save time, show you this PowerPoint. This one is 12 months old, very young child, very high AFP. When you have a very high AFP, you really need to consider this could be hepatoblastoma, because that's the most common malignant tumor in this age group, less than 2 years old, less than 3 years old, those may be like congenital, so you need to think about it. So for any time you deal with the liver tumor, we already, with surgeon and oncology, we are consensus. Anytime we do this kind of biopsy, submit tissue, fresh tissue. So we should do touch imprint to make sure we have enough, like adequacy, we have enough tumor. So that touch imprint looks like a cluster of small blue cell tumors, and they're a high NC ratio, and they have epithelial appearance. And we not try to make a diagnosis on the touch imprint, just like you do cytology, just triage the tissue, make sure you have enough tissue. Then you can divide the tissue, see if there's enough. Of course, first priority for permanent to make a diagnosis. If enough tissue, we see some fresh for because COG. There's every child that kind of enroll the patient for trial, and also see some for possible genetic testing, and that's what we do. For this specific case, I want to show you that D5 is like a dark area, light areas, kind of fetal type hepatoblastoma, and close look the same. Hepatoblastoma, in general look similar, especially to fetal and embryonal. So you get this like a fetal liver cell looking, some light area. What I want to show you is that these cases have lots of extramedullary hematopoiesis. And this is the embryonal type, high NC ratio. From the extramedullary hematopoiesis, if you go back and look at the digital slide, you will find a lot of these cases. And there are areas have like a megakaryocyte differentiation. I want to show you this one. So when you have some area, some looks like a small cell, you want to do INI1, as I said, we usually do INI1. Then when you do INI1, you come out of this small focus. There's no staining, loss of staining. So nuclear staining that other tumor cells, that's what this is. But this doesn't look like a small cell and differentiated type when you look at the HE. So why this will have lost INI1? So that time, so this is small cell or not. So I have to confirm this is not a small cell. So I did the glycophorin one that highlight erythroid precursor membrane. So confirm this is really extramedullary hematopoiesis, erythroblast. It's not a small cell. So just want you guys know, now it's everyone knows extramedullary hematopoiesis going to have a negative RNI1 staining. So do not be fooled. Like me, the first time I encountered, that's probably 10 years ago. That time I said, why is not lost staining? We are trying to do a project at that time. Why have staining? I don't know why there's no INI1 staining for this extramedullary hematopoiesis, but you just remember, look at the HE. If it looks like it's not a small cell antigen type, looks like extramedullary hematopoiesis, and those are going to be negative for INI1. So do not be scared. So how I send this case out, called the liver mass right lobe incisional biopsy, hepatoblastoma epithelial type with fetal and embryonal component, no small cell undifferentiated or rhabdoid component. Because initially I look at that case as why INI1 have lost expression. So always make me remember this case. So when I do the tumor board, I would just share the experience with everyone, put that. So that for that D5, you can look at your digital slide yourself. So now we move on. That's all about hepatoblastoma. Then let's talk about D6, 9 months old. Is pediatric pathology for, we deal with so many young people, like a 9-year-old, very young. And this one, AFP, kind of high, but not very high, like the other first 2-3 cases. It's kind of not very high. Whenever it's not very high, we are thinking, is this hepatoblastoma or not? Because hepatoblastoma usually very high. So again, we did like touch imprint, Oh, let's go to digital slides. D6. D6. Again, it's liver. On this specific scan slide, I didn't find much normal liver, all tumor. And the sheath of tumor, you close look. Maybe there are some entrapped hepatocyte, the pink one. And the right is a sheath of small cell. Kind of, there's no differentiation. You look around everywhere, it's just small blue cells. Not blue, this actually is pink. I never told them this, we are looking at the pink cell things. But there's not like we see the first 3 cases have, epithelial appearance. This one do not have much epithelial appearance. There's an entrapped bile duct. So infiltrative, small cell appearance. And some area have like a mixed solid background, and some area with like a necrosis, neutrophils. But you really cannot tell from this histology what kind of type is. 9 months old, here's necrosis, 9 months old. So, is this small cell hepatoblastoma or rhabdoid tumor? Of course, we do immunos. And this case have a nuclear loss of nuclear expression for this case. So this one case is rhabdoid tumor. It's not hepatoblastoma. And rhabdoid tumor, I think you guys see rhabdoid tumor often with, we usually think of rhabdoid cells is large epithelial cells with eccentrically located nuclei, cytoplasmic inclusion. This one we did not see. We only see what we saw is just some indifferent small cells. So you have to do INI1 to get the diagnosis. So that's the case. So that's D6. Touch imprint, you see cluster of tumor cells, epithelial looking, have some cytoplasm. Actually, here you can see some eccentrically located nuclei, but you did not see the cytoplasmic inclusions. That's the biopsy. You have a residual hepatocyte a little bit. Small cell, and that's residual normal hepatocyte. You can compare. That's epithelial hepatocyte. That's indifferent small blue cells or pinkish cell, entrapped bile duct, indifferent cell with prominent mitosis, mixed solid background, and the tumor cells. Indifferent from small cell and different type that have no expression of anything. This tumor positive for pancytokeratin, epithelial marker. Positive for EMA epithelial marker. So Vimentin also positive. Hyper-1, the entrapped hepatocyte positive, those tumor cells are negative. There's no hepatocyte differentiation seems. Beta-catenin also negative. Glypancon-3, the tumor cell negative. All those 3 panels different from hepatoblastoma. AFP also negative. CK7 is negative because that time we also, when we order the test, also want to rule out the yolk sac tumor because those may make a solid component. So yolk sac tumor usually CK7 positive, AFP positive, this one's negative. Most important is INI1. There is a loss of nuclear expression for INI1. This is an entrapped bile duct as like an internal control. You can see the nuclear staining and the tumor cell totally lost. So by this morphology, by this INI1 staining, so the diagnosis is malignant rhabdoid tumor. That's how it stands out like this case. If you have a question, maybe I should answer a question at the end.
Yeah, let's do the questions at the end so that we make sure that we get through all the things, because I think they'll have some good discussion on some of the points that will be a good review as we go back.
Okay, so D11. D11 just quick show you another case of rhabdoid tumor, give you morphologies. It's not a liver. This one patient had a history of rhabdoid tumor of a kidney, and there's lung metastasis. And this is also a rhabdoid tumor, and epithelial is a more classic rhabdoid feature of prominent nucleoli, but still you did not see the typical inclusions, but you do IN1, you're going to have INI1 loss. So just show you some other feature of rhabdoid tumor. Usually have very prominent nucleoli, rhabdoid tumor. Okay, go back to D7. D7 is 16-year-old. That's older. To us, it's older for pediatric pathology. 16-year-old, also liver mass, did a resection. AFP is not increased. This gross picture of the resection, the cut surface, that's a little bit residual normal liver. The whole tumor is very hemorrhagic, edematous, some hemorrhage, some necrosis. That's D7. Let's look at the D7. Okay, D7, you can see the blood necrosis, cystic change. And you look at on the edge, they're a little bit normal hepatocytes. That's a little bit normal hepatocyte on the edge. And then you look at the tumor. Tumor is not encapsulated, although it's kind of relative well circumscribed. And you look at the tumor morphology. They're more like spindle cells, pleomorphic, some large, very large atypical cells. And some have a cytoplasm, the granular pink granule. And there's no epithelial differentiation. So very pleomorphic. And mitosis is very prominent. And that's necrosis. Try to avoid this necrosis, try to avoid this area. That's like a edema. And this area also exists spindle cell, very pleomorphic in the liver. So it's not a hepatocellular carcinoma. It's not hepatoblastoma. Looks like more like mesenchymal tumor. With this kind of morphology, differential could be embryonal rhabdomyosarcoma or another entity called the indifferent embryonal sarcoma. It's not the carcinoma, sarcoma. See mitosis. And characteristic for this indifferent embryonal sarcoma is a spindle cell, very pleomorphic, and also diagnosis of exclusion of other sarcoma. The features I want to show you is the cytoplasm granules. Slow down. Not sure you can see it, very pleomorphic. I think I can slow down. Okay, let me just show you some picture, probably easier to see. So very edematous mesenchymal component looks like. Some very pleomorphic cells. These are like very atypical cells. And there's something I want to mention that mitosis and cytoplasm granule, pink granule, we call the hyaline globin. Hyaline globin. This kind of feature for this diagnosis, embryonal sarcoma. And those granules, you can use PASD staining. You can highlight those granules, hyaline granule. Of course, you want to do some immuno to rule out hepatoblastoma, rule out others like rhabdomyosarcoma. For this specific case, myogenic negative, decimine negative, rule out rhabdomyosarcoma. Glypan-3 hyper-1 or negative, rule out hepatocellular carcinoma or hepatoblastoma. IN1, there's no loss, so it's not rhabdoid. Also, of course, the morphology does not fit either, but we do it anyway. So alpha-fetal protein negative. So there's a little bit, we call the perinuclear dot staining for pan-cytokeratin. So the diagnosis, phenodactyl liver mass right lobe is indifferent embryonal sarcoma of liver. Because very unusual entity, with just quick summary, is account for 9 to 15% pediatric hepatic tumor. is number 3 after hepatoblastoma and hepatocellular carcinoma. Usually age 6 to 10. Also, people says exclusively in pediatric age. In children, often associated with mesenchymal hamartoma. The same gene change seen mesenchymal hamartoma and this tumor. So that's why the people think that's probably this is benign version and this is malignant version. They are all mesenchymal. Rarely you can associate with vaginal embryonal rhabdomal sarcoma for this case. So this is diagnosed indifferent embryonal sarcoma of liver. So remember clinical history, there's no increased fetal AFP, fetal protein. So we move on, number this 13, this is a 10 months old girl with a liver mass, identified incidentally due to 2 days of nausea of vomiting. AFP is slightly high, little bit high, not as hepatoblastoma that high, but 10 months old, you often think about this could be hepatoblastoma, but it kind of incidental finding. This is surgery, so very big tumor compared to 9 months old. That's the gallbladder. So that's on liver tumor on the right lobe. Before this is this abdomen. I think that's head. The liver, the tumor totally excised. That we received the specimen. There's a little normal liver on the left, and this right lobe. Whole thing is big tumor. So that's the tumor is intact. This is cut surface, a big cystic tumor, very mixed solid change. So that's our case number, what the number is, 13. Number 13. Okay. Now, I think our server start to slow down.
Yeah, we're getting towards daytime, so more users are on the server.
Okay, now it's okay. So that's the low power view. That's the residual liver cells, hepatocytes. That's a normal residual normal liver, and that's the big mass. Well circumscribed but not encapsulated. And you can so many like a pink nodule, not pink, pale nodule, and there's edema. Close look. So there's a cystic dilatation. All those is bile duct dilatation, irregular bile duct dilatation. There are lots of like spindle cells, mesenchymal component fibroblast. There's bile duct, and there's some liver cells. Kind of mixed everything. Suppose we see in the normal liver, you have a hepatocyte, bile duct, fibrous tissue like a portal tract, and you have some vessel. So it looks like everything looks like normal liver tissue we supposed to have, but just disorganized, arranged, like organized, organoid arrangement. Have bile duct, fibrous tissue, liver cell. So this is called hamartoma. The predominant abnormal tissue is like mesenchymal component. So that's what we call the mesenchymal hamartoma. So mesenchymal hamartoma is to go everywhere you can look. And it looks like a benign appearance. This normal, looks like a normal hepatocytes, but architecture-wise distorted. You have bile duct, cystic dilatation, and you have some vessels. So that's mesenchymal hamartoma. There's a big cystic degeneration we see on the growth. So that's just a capture of that. We just see it. So that pale edematous change. That's vessel. That's the bile duct. Bile duct irregular, spindle cells, some vessel, edematous change. So how did I sense this case called mesenchymal hamartoma? It's a benign tumor, completely excised. So I'm talking this one with the previous one and different embryonal sarcoma. These share the same gene mutation, so that we put them together. So that's why if you have a although it's benign mesenchymal hamartoma, recommendation is complete size, just in case later on develop into or like a malignant transformation into that undifferentiated mesenchymal sarcoma. It's almost 8 o'clock. Dr. Hassel, should I continue?
Oh, yes, let's finish this or go forward. Yes. We
Okay.
have a few more minutes.
Okay. So 8 is 11-year-old girl liver mass. We first did a core biopsy, made a diagnosis, then we did a resection. At the time of diagnosis, the AFP is low. So very important for us to check AFP level. You have liver, you have big mass. If AFP high, you would consider hepatoblastoma or hepatocellular carcinoma. But when you have a low AFP, you would wonder what is it, sarcoma or something. So D8. This resection after chemotherapy, the patient did not respond to chemotherapy, so did a resection. The morphology is similar to the initially biopsy. So there's a little normal liver here, and this is the tumor cells. Just want to show you some feature of these tumor cells. These tumors are very large, and plenty of cytoplasm, nuclear very big, and there are some nucleoli. So sometimes cherry red nucleoli. The tumor cells very large, arranged like a cord or pseudoacinar, kind of hepatic cell looking, but too large compared to normal hepatocytes. And let's start to slow down our server. Okay, so the feature of this tumor is very large pink cells. And if you look closely, there is some hint of fibrous band. Although this one is not many. You do have some hint of some fibrous band. You see here, little fibrous band. So differential could, this morphology could be seen in the, if adult, you think about melanoma, very large cells. But in this one, specific for a type of hepatocellular carcinoma. Okay, slow down. Let me show you the time I did for the tumor board. This is biopsy, a similar morphology, and there's a fibrous band. Cellular is a very large cells, have nuclear inclusion, pseudo inclusion, and you have bioproduction actually. Cytoplasmic granule looks hepatocyte, but just too big, too large. And look carefully, often can find this we call the pale body or hyaline body. So this is a feature of this tumor, in addition to the cellular morphology. This PS highlighted those hyaline body, pale body, and you can do PSD or this hyaline body. And looking for those fibrous tissue, sometimes very prominent, sometimes not obvious. For this specific, it's not obvious, but you do see some like laminated fibrosis like this. Trichromo stain usually better. And this tumor, of course, positive for HERPA1, so demonstrate this is a hepatocellular tumor. Then, indifferent for regular hepatocellular carcinoma, this tumor is strongly positive for CK7 and positive for CD68. And of course, you want to rule out a rhabdoid tumor, you do NI1, there's no loss for nuclear staining. So this morphology is classical for fibrolaminar carcinoma. It's a variant of hepatocellular carcinoma, usually seen in the pediatric patient. And for this specific case, we did a FISH for this specific gene rearrangement is positive, which confirmed the diagnosis. And feature for fibrolaminar hepatocellular carcinoma is large tumor cells with prominent nucleoli, positive for HERPA1 and CK7, CD68. Serum usually have normal serum fetal protein, no history of chronic liver disease. This is important for us to distinguish this type with regular conventional hepatocellular carcinoma, because in pediatric population, conventional hepatocellular carcinoma usually developed in the liver, have disease, background disease, have cirrhosis, have alpha-1 antitrypsin deficiency disease. So if you diagnose a regular hepatocellular carcinoma or hepatology usually want to make sure there's no background liver disease. Compared to this specific variant that usually do not have chronic liver disease. So don't need to work on, usually don't need to spend too much time work on the background liver disease. So we tried our best to differentiate fibrolaminar from conventional HCC. The same patient get a resection later on. So that's what slide taken from. So large tumor cells, this is residual hepatocyte. So big one. And you see this resection from the slide you get, you still have some like a hyaline body, some pale body, this kind of case. Next one, D10, similar to this case, probably just quick show you. I don't know, can we run or not now? 10, okay. Same diagnosis, just this one is more obvious because last one do not have much fibrosis. So I want to show you a more classic case. So this one is similar large cells. The cellular morphology also same large cell pronucleoli. You see this lots of fibrosis. So if you encounter like this kind of fibrosis, usually you have no question diagnosis of fibrolaminar HCC. The problem is when you do like a biopsy, sometimes really need more workup. So that's the D10. Also, it's a 15-year-old normal AFP. That's a biopsy. Also look large cells, CK7 positive, CD8 positive. We also did gene fish. It's also positive for that. And that's the resection. Classic the fibrolaminar carcinoma HCC have those like a central scar looking. So that's the central scar. And from this scar come out those fibrous laminar. Patient dissect the fibrolaminar. So that's a trichome. So you can see that fibrolaminar pattern. This is one is classic. So this one is what? Yeah, D10 is more classic for fibrolaminar hepatocellular carcinoma. So this one we send out like fibrolaminar hepatocellular carcinoma. I think this is the last one. Last one is a 13-year-old girl with history of Hashimoto for 1 year, have left arm numbness and weakness. There are multiple lesions in the bone, spine, vertebrae, and the liver. The liver is not a big mass. It's kind of scattered, looks like an initial thought could be like a metastatic disease, multiple nodules. We did an ultrasound guided core biopsy. That's D9. Okay, that's D9. So that's the liver core. And on this side, there one end looks like a normal liver. So you have a portal tract, you have a normal liver. You move around, still normal, still normal. We count this area is kind of little different. That looks like a portal tract, but very enlarged. And kind of some cells does not look like a liver cells. And if you continue move this area, it seems to have a hepatocyte drop. Hepatocyte drop. Have some hepatocyte left over, but you still have some like those kind of cells, a little bit different from hepatocyte. Very subtle, but you do not have normal architecture. There's some residual bile duct. And go here. And some leftover hepatocyte, but they also have some background fibrous tissue looking. Very difficult to tell which one is tumor, which one is hepatocyte. Is the case. So some cells, those looks like a tumor cells. Some maybe between the tumor cell, there's this kind of spindle cell a little bit. Some cell have like a form like a cytoplasmic lumen with red cells. Make you think about it could be vascular tumor. There are some lots of vessels. So that's A. I'll give you D9B, that's CD34. Low power, you can see there's normal liver, not much staining. Only the portal tract have those vascular staining. And the area kind of disorganized, the lesional area, you can see much more increased staining for CD34. And I did a CD31 and the factor 8 get a similar pattern. Do looks like a lot of vessels, vascular proliferation, this area, vascular channel, especially this area. So there's lots of cells here. So do have lots of vascular channel. So with this morphology, looks like epithelioid, looks a vascular tumor. So we think of epithelial hemangioendothelioma. I'll give you this last slide. The stain is Campta 1. So you can see there, normal liver negative, and the disorganized area kind of positive. It's a nuclear staining. So with this diagnosis, this staining make diagnosis of epithelial hemangioendothelioma. You still, with this stain, you still can see a lot of normal liver tissue intermingled with these cells. Those cells form cord. It's not every cell in this area is tumor cells, but you do see some tumor cells with the positive staining, kind of a subtle. So just some few images are catched on the for our tumor board. So that's the area, abnormal area. You can see fibrous background. Hepatocyte drop has some pale cells, like the pale cell like this. And close look, some looks like try to form lumens, some vessels. This one is more characteristic, I think. That's the liver core, and stuffed with those kind of pale pink cells. Those is epithelial appearance, and these are tumor cells. Looks like in the sinusoid infiltrating type. And the CD31 vascular marker, you can see the tumor cells positive. CD34 at the USC here. That's the factor 8. Some are really tumor cells, some may be like a megakaryocyte or some difficult to tell. But with all three vascular markers are positive, we really think that this is vascular tumor. Of course, we have one rule to others because very subtle, so we have to rule out possible anaplastic large cell lymphoma, infiltrate, sinusoid infiltrate because some large pink cells. We did CD30, ALK1 is negative, rule out this. Some rule out other epithelial sarcoma or rhabdoid tumor is no loss of INI1, also no pancytokeratin EMA expression. So we basically rule out this. And also we try to rule out rhabdoid sarcoma, also not looks, the morphology doesn't looks like, but we have to do that. So desmine myogenic negative, rule out that. Also, we think it could be sinusoid infiltrated by myeloid sarcoma, AML, because patients have multiple lesions in the bone, the vertebrae. So we did this CD43, CD56, they are all negative. So then in the meantime, we send this case for this special stance. It's sent out to Mayo Clinic, take a few days, so we have to wait. So when we do tumor board that time, we do not have that yet, but later on we get this staining, as you see, positive. So for this case diagnosis, epithelial hemangioendothelioma, I just quick mention about the Campta 1. Campta 1 protein overexpressions in nucleus is the result of this WWTR1 Campta 1 gene fusion. So you can do gene fusion, or you can just do, let's say, immunostain. It's more than like approximately 90% epithelial hemangioendothelioma going to be positive by this overexpression. So I usually do immuno, do not do fish. If you really want to do fish, you can do it. But I think usually immuno is very sensitive and quick and cost less. And right now we use this one to distinguish epithelial hemangioendothelioma from other tumor with epithelial morphology. I think this is the last case.
Very good. So just a quick question on this one from Kalyani, who asks whether or not you saw vacuoles or blister cells, which are also seen in this sort of a case. Is that right, Dr. Yu?
Which one? For
the epithelial hemangioendothelioma, yeah. Yeah.
You suppose if you're in soft tissue, usually more obvious. For this specific case, because it's kind of so many normal liver tissue, I think we do have some like a cytoplasmic vacuole, looks like have erythrocytes.
Yeah, I think you have some pseudo blister-like cells in there as well.
Yeah. They usually have it.
And as you say, most people are using the CAMTA1 immunohistochemistry rather than doing FISH because of the cost and speed and so forth of that assay.
Correct.
Yeah. Well, that's a very great case. And I think the other clue here, of course, is the fact that she had multi-organ disease.
Yeah.
That should certainly steer you in that direction as well.
Correct. Yes. So that time they don't know, is metastatic disease or is this endothelioma, because the bone biopsy kind of usually harder than liver biopsy. That's why we had the liver biopsy.
Right.
So the bone lesion could be like a metastasis, but also could be like a multifocal. This tumor can happen like a multifocal disease. Yeah.
So we have another question from Dr. Tu, who asks or says that it's sometimes challenging to differentiate hepatoblastoma from hepatocellular carcinoma. In your experience, how would you differentiate these two entities? Does immunohistochemistry help, for example?
Okay, for hepatoblastoma, usually patient age is young, and the AFP usually sky high. For hepatocellular carcinoma, age usually older, and also have a background liver disease, cirrhosis. That's for clinical part. And hepatocellular carcinoma usually do not have that sky high AFP, but do have AFP increase. But there's no immunomarker to differentiate hepatocellular carcinoma versus hepatoblastoma. It's purely by the morphology. Hepatocellular carcinoma cell is large, have a trabecular arrangement, big trabecular, microtrabecular arrangement. There's sometimes really challenging. So there's we have a new entity called the hepatocellular tumor NOS.
Yeah.
So this entity between the hepatoblastoma, hepatocellular carcinoma. Sometimes challenging.
Okay, good. So here's another question. If CAMTA1 is negative, does it completely rule out epithelial hemangioendothelioma? Could it still be a YAP1 TFE3 fusion and still be a epithelial hemangioendothelioma?
Yes, if you get immunostat negative, you should go to a gene test.
Yeah. Okay.
Or another pair. There are two pair, another pair as well.
Yeah. So that would expand the differential a little bit, but as you said, 90% plus of cases will be positive with CAMTA1.
Yeah.
Well, I don't see any other questions coming in, so I just want to thank you, Zhongxin, for doing a marvelous job in explaining a very complex array of cases with the hepatoblastoma and the differentials involved. The digital slides being posted, of course, people can go back and review those. Your PowerPoint slides have very well illustrated the high power features that sometimes we miss on those digital slides. So I just want to thank you again and thank our audience for great questions. And we will look forward to posting this video for people to review later on. And for some of our listeners who didn't get to tune in on time or were delayed otherwise. So we will end the program now and look forward to meeting again in a month.
Oh, thank you.
Our pleasure. Thanks so much.
Thanks.